Welcome to a conversation on supporting self-management in children and adolescents with medical complexity. My name is Rishi Agrawal. I'm an associate professor of pediatrics at Northwestern University Feinberg School of Medicine and a pediatrician at Lurie and La Rabida Children's Hospital in Chicago. Today's discussion features one of the articles from the March 2018 issue of the Pediatric supplement entitled Building Systems that Work for Children with Complex Healthcare Needs, which I co-edited with Chris Stilla from Colorado. The articles in the supplement feature writing from leading healthcare providers, family representatives, advocates, policymakers, and researchers. The hope is that these articles will help to clarify some of the difficult systemic issues and challenges affecting healthcare for these children and point the way toward their resolution. Today's conversation is hosted by the Lucille Packard Foundation for Children's Health. You can access all of the articles in this series and stay up to date on future conversations by visiting their website, lpfch.org/AAP supplement. A few housekeeping items before we begin. We want this to be a lively discussion and encourage attendees to ask questions. You can submit questions in the GoToWebinar question box. Thank you to those of you who have already submitted questions ahead of time. We will try to get to as many as we can. All attendees will be muted for the duration of the webinar. A recording of the webinar and the slides will be posted on the Foundation website and shared with all registrants via email. Now I would like to introduce our panelists for today's conversation. We are very pleased to welcome Dr. Amy Houtro, Chief of the Division of Pediatric Rehabilitation Medicine and Vice Chair of Physical Medicine and Rehabilitation at the Children's Hospital of Pittsburgh. Amy is a lead author of Supporting Self-Management in Children and Adolescents with Complex Chronic Conditions. Amy will review the article's key content and discuss how health systems could better support self-management by pediatric patients and their families. Joining us today are two great experts in the field. I'd like to welcome Melissa Novotny, who is a nurse practitioner at the Pediatric Complex Care Program and Pediatric Cerebral Palsy Clinic at the American Family Children's Hospital. And I'd also like to welcome Dr. Avani Modi, who is Professor of Pediatrics and the Director for Adherence and Self-Management at Cincinnati Children's Hospital Medical Center. Welcome to you all. We will start the conversation now with a few words from Amy. Over to you, Amy.
Thank you, Rishi, and thank you guys all for joining us. I am a pediatric rehabilitation medicine physician, which means that I think about how children can be as functionally capable as possible, meet developmental milestones, and develop independence. So this issue of supporting self-management is particularly critical to the children that I care for, and I'm delighted to be here and share this with you, and then also share the question and answer session with our panelists who are experts in this area. Basically, from a healthcare perspective, self-management is the set of tasks that individual people take when they have chronic conditions to keep themselves as healthy as possible. So that's what we're going to be focusing on today. So some of the things that people with chronic conditions address are the signs and symptoms of their conditions. They might be monitoring the signs of high blood pressure, for example, which isn't symptomatically noticeable, or they might be monitoring their GI symptoms if they have inflammatory bowel disease. And another aspect of important for self-management is adherence to medication protocols and other treatment routines. There's a full continuum of what self-management is really about. There are very condition-specific activities, such as taking one's medication or checking their blood glucose, or in my population, children with disabilities, donning their AFOs and doing other things that allow them to be functionally capable. Then on the other end of the spectrum are things more related to general wellness, which all individuals are taking part in, hopefully. So things like eating a healthy diet, exercising regularly, and coping with stressful situations. Those are all things that people with and without chronic health conditions are addressing. And then briefly, the unique nature of self-management tasks for children who have a role with their parents. So when children are very young, their parents take entire responsibility for their self-management. Things like giving their children medicine or putting on their braces. And then as children grow, they take on more responsibility, hopefully, and manage their healthcare needs in a shared management model. And eventually we work towards independence. So for youth, that would be things like being able to call in their own prescriptions, or for children with insensate skin, for example, checking to make sure that they do not have skin breakdown. I want to highlight some other really important pediatric considerations, and I want to do that because there's some things about pediatrics that aren't mirrored in the adult space, except for adults who've had very serious injuries and illness that limit their capacity to do things. And that's dependency. So all children start out as completely dependent on others. And most children, even the ones with the most complex healthcare conditions, are able to develop some amount of decreased dependence or independence. They may need continued help with certain tasks, but it is often that they develop over time to becoming more and more independent. And that's because children have a developmental capacity. And we're going to talk briefly about the importance of thinking about capacity on the next slide. The other piece that's different in the pediatric space is that the epidemiology of the conditions that we see are very different than the epidemiology of conditions seen in adulthood. There's growing literature about self-management techniques and moving the field forward in pediatrics, but it started out as utilizing information about self-management in adult common chronic conditions. And in pediatrics, we have to remember that many conditions are common, such as asthma, but there are other conditions that are quite rare. And as a rehab doctor, I think a lot about capacity, or someone's ability to do something. So capacity means what you're able to do in a controlled environment. Capability is what you can do in your own environment. But really what we're trying to tackle here when we think about self-management activities is what the person is actually able to do. So what they're doing in their own environment. So here's an example of a child who is using Lostrian crutches, practicing with a physical therapist, walking in a controlled environment. So they have the capacity to do it. And then another child who has performed this activity is able to do it in their own environment and is actually doing it. And this is what we mean when we're thinking about proficiency for developing skills and being proficient at a skill that might be required for self-management. People start off in a novice space and then they advance up. Many of us never really feel that we become experts or highly proficient at things. But what we want is to set up the opportunities for individuals to develop that proficiency. And that requires going through these steps and then demonstrating skills at these levels that are consistent with that. And a lot of this requires repeated practice. So many people talk about how their child could do something, but their child doesn't do it because it's easier for the parent just to do it. And this is where we really need to work with families to talk about moving that responsibility from mostly the parent to shared with the child, to then through the youth taking on more and more responsibility. And this is how we get through a hierarchy of proficiency. But I want to contextualize this a little bit further. And we are very, very lucky to have Dr. Moody on the line with us, and she'll talk about this more. But when we think about the management activities, they don't happen in a vacuum. So in pediatric self-management, the behaviors that are involved in self-management, they don't operate in isolation. They exist within the context of that individual, what they have as a sense of their own autonomy and desires, their capabilities. It also functions inside their family, what their values are, their community, and the greater health system at large. There are both modifiable factors and non-modifiable factors at play here that can be impactful. And we as practitioners need to attend to those and be alerted to things that we cannot change and be paying attention to the things that we may be able to influence. So we're going to dig just a little bit deeper conceptually into that, because some of the things that are really important to elevating people's ability to perform self-management are things that are very core to the individual themselves, such as having a feeling of self-efficacy, that I can do something if I want to, and having autonomy, to be able to make decisions and judgments and believe that they have the ability to do that independently. This is in addition to the baseline physical and cognitive capabilities that a person might have, and that allows them then to practice skills. You have to feel that you can achieve before you set out to try. And we want to set up an environment for our patients and families where the opportunity to try is there, and that the desired outcome, success for self-management, is achievable. And we know that the interpersonal relationships are extremely important. We understand that the role of a parent is to provide care for their child and then help them grow into independent, functional adults. And that is the context in which this is happening for self-management for children, and it's dynamic. Each member of the dyad, or if it's a mother and a child, or the family unit, is influencing and responding to the others. So we have certainly probably seen this in our clinics, where there are different goals than one parent has than the child does, or one parent from the other parent. And so understanding the interpersonal milieu is essential for really helping promote self-management. We also need to think about this in terms of timing. The shift or transfer of responsibility can't happen all at once. It needs to be over time and incremental. To just turn off the light or turn on the light switch isn't what we should be promoting here. It should be the gradual change from management by the parent to shared management to eventual self-management. And we know that there are many environmental contextual variables here, and that they happen at multiple levels. And we need to be thinking about this when we think about how what factors have been influencing whether an individual can achieve adherence with a medication regimen, for example. So when I think about supporting youth in self-management, it comes from the basic framework that I have about wanting to promote independence and developing skills. And that importance of independence needs to be instilled from a very, very young age. Across childhood, children go through a number of transitions. And an example of that is getting ready for school. Many of our children are having their first days of school this week, and promoting their ability to do that successfully, their independence, their self-efficacy, is something that happens from a very young age. And we should be adding self-management goals to our care plans. And in that, one of the ways that we can really support the ideas is to think about not just what those goals are, but why the goals are important, making sure that everyone agrees and understands, and then identifying what it takes to achieve that goal, identifying who is responsible for what role, and how success will be measured, and then how often that success or progress towards that goal will be assessed, because these all help us achieve goals. When we set a goal but don't have a pathway to it, it becomes overwhelming. One of the key concepts here is this idea of behavioral change counseling. And you do not have to be a psychologist to do this. Physicians engage in behavioral change counseling. Nurses and nurse practitioners engage in it as well. And really what it's centered around is a personal action plan to assess beliefs, behaviors, and knowledge, to advise and provide education, to agree on goals, assist by addressing needs and barriers, and arrange for appropriate follow-up support. It's about moving a goal forward. And just briefly, I want to just show you this graphic of shared to self-management, because it uses language that I think can be really helpful. It takes it out of a medical frame to being more in the kind of business language. And I think that can be helpful so it can destigmatize some of the aspects of roles. And certainly in the very beginning, the parent is a provider and the young person receives that care. But as children age and they're providing more of their own self-care, the parent is doing some management of that. And as the youth or the young person becomes better at it, they are starting to manage, which means that the parent can be more of a supervisor. And eventually they become a consultant as the youth becomes a supervisor, and then eventually the CEO of their own care, which is ultimately what we want for all individuals to be able to achieve. And I want to point out that this seems very challenging, that the tasks about counseling and goal setting should not be left to just one member of a team, and it's not solely a physician or a nurse practitioner's or a psychologist's role. Everyone should be involved who's involved in the care team. And so that's the individual themselves, the young person, their parents, nurses, social workers, educators, to really have a team-based approach. But in a team-based approach, we should be making sure we're defining our individual roles successfully. There may be overlap, and that's often quite appropriate, but we want to make sure that we're not being duplicative with our activities. And then when possible, we all know that this is an issue, that services should be billed so that we can be compensated for the activity. In the article itself, there are some examples of billing codes and ideas about billing. I take care of children with disabilities. That's my entire clinical practice. And many of these individuals are limited in their ability to participate in self-management activities. And so sometimes these children will never achieve independence, but that doesn't mean that we don't promote it and that we don't work hard to achieve as much independence as possible. But simplifying routines and giving structure can be very helpful for an individual with disabilities to take on more responsibility. It may be by setting up adaptive support, such as a timer on a watch to remind them to do something. It can even be an alert that shows up on an iPad that shows a picture of the medication that cues the individual to take that medication. And we always want to continue to empower youth with disabilities to develop new skills and to develop self-efficacy. But we want this to be through goals that are achievable and realistic, because failure in achieving goals is a setback for youth, and we want to set them up for as much success as possible. And then planning for the transition phase to adulthood and setting up necessary supports and thinking about opportunities for continued independence and autonomy. So thank you, and I will turn it back over.
Great, thank you, Amy. Now we're going to turn it over to Melissa, who's going to give us some thoughts from her perspective. Go ahead, Melissa. And Melissa, if you're on mute, just make sure you unmute your line.
Thanks, Tracy. Yes, I was on mute. Hello, everyone. Thank you for allowing me to be a part of this important conversation. I'm a pediatric nurse practitioner, and I practice at the American Family Children's Hospital in Madison, Wisconsin, in the Pediatric Complex Care Program. And we roughly take care of 250 children and adolescents with a wide range of medical complexity, along with a wide range of mild to severe developmental and cognitive delays. And so I really appreciated the work the authors put into this article, because it provided me a great opportunity to reflect on how I personally approach self-management with my patients. And it also sparked some thought about the unique challenges healthcare providers may face as we support self-management in our complex patient population. So my key thoughts I'll talk about really stem from a frontline healthcare provider perspective. My first key thought follows much of what this article, is getting at and asking, and how do we actually go about helping families transition control from the caregiver to the youth? And how do we calibrate this to the unique needs and skills of each medically complex youth and family? I echo this article in that we are in a unique position as healthcare providers when caring for children with chronic and complex medical conditions. The approach is not straightforward or black and white. And our patients fall on a wide spectrum of developmental, cognitive, behavioral, and functional abilities. And I appreciate that the pediatric self-management model is not disease-specific, but rather offers an open-ended, broad approach to self-management. I think there are some further unique challenges in supporting self-management in this patient population. When reflecting on my own practice, I wonder if I often limit my patients' potential. We enroll children in our programs who are medically complex, and we approach them as medically complex. And I think I often focus on the medical management and preventing complications, and I may often lose sight of their abilities and really optimizing their potential. So this article brought about a lot of self-awareness in how I have been approaching my patient care and how I want to move forward. Another challenge I have faced in my own practice is that children are oftentimes born with significant medical complexity, but as they get older, they become less complex over time. I find that parents are accustomed to providing a high level of care to the child, and they find it difficult to loosen the reins or switch gears to teach the child to be independent. So how do we help these parents make that transition from fully hands-on to promoting independence in their child that has always relied on them? Is kind of a question that that came out of this for me. And my next key thought is, what are feasible practical tools to bring self-management into practice today? I reflected on my own practice again and how I incorporate this important element into my patient visits, or how I can incorporate them into my visits really today, but without significantly impacting my workload. So our complex program at AFCH here in Madison, we recently initiated what we call a shared plan of care for our patients, and I feel this could be an ideal place to incorporate supporting self-management. And that kind of echoes what Amy addressed as well in her slides. But the shared plan of care, it's a comprehensive document that contains specific elements that are addressed for each patient. And in our document, it includes an About Me section, a patient and family goals section, a medical summary section, and then a section that outlines the patient's, essentially their social history and the family preferences and values and what their priorities are. Our providers then create this document and it's placed in the electronic medical record, and so that it's readily accessible by all providers in the health system. And then it is also given to the families so that they can have a copy of it, and see their goals, and then they can provide this to the school and other community resources. Again, I think this tool has the means to provide several key elements in supporting self-management. So first, it includes goals that are created collaboratively with the child and caregiver and the provider during clinic visits. And I think this could be a great area to specifically discuss self-management and create goals. This document also includes the social history and family preferences section, which could really be an essential area to access information on family strengths and needs. And this can include, the patient's home life, what their family makeup is, their housing, transportation, and what community resources they may be linked to. I really appreciate that this article points out the importance of understanding the environment a child and family functions in, and really understanding those modifiable and non-modifiable factors in their lives. So that is key so that we can set these patients up for success. Another thing that I want to bring up is I also think that, healthcare providers or specialists are under time constraints, and the majority of their visits are comprised of disease management. And I can only imagine, it's difficult for them to really obtain a detailed social history and kind of get down to that nitty-gritty of what may impact this family. And I think that, us as complex care providers, we're in a unique position to develop these relationships over time with patients and their families, to really understand the environment that they live and function in, and really, kind of get down to what their strengths and weaknesses or areas of need are. And then we use this document and we can outline this in this shared plan of care document. And it provides a way for providers to rapidly access it and get a quick sense for possible strengths and barriers the child may face when they're making their recommendations and treatment plans. My third key thought is that many providers, we innately partner with families and patients to identify goals and address challenges. That's what we do as providers. But a question I want to pose to the listeners, to the other panelists, is how do we really approach self-management support in a way that is consistent, systematic, and proactive with each patient each time? For me, I think, moving forward, this shared plan of care could be a great means of ensuring that this is completed. And I also want to point out in the article, I really like that in Figure 1, there's a list of the self-management tasks. And I wonder if there's a way that, a tool could be created that helps us providers systematically address these tasks over time as the, child transitions into adolescence. And I think this could be a great area for to further explore. And then finally, I just have a couple other questions or thoughts that came to mind. So, how do we efficiently collaborate with caregivers and youth to develop these goals that are realistic, measurable, and sustainable? And Amy, you actually had some great slides at the end there that kind of answered some of those questions for me, or things to think about. But, really moving from self to shared management with each goal, we really need to define the role of the caregiver and the role of the youth in obtaining that goal. And I feel like looking at how we create goals can be a little bit of a daunting process. Not to say that in a negative sense, but we really want this to be meaningful for the child. So how do we efficiently, have a systematic approach to creating goals with families? And I would be curious to know if other panelists have any tips on how to create goals that are meaningful for the child. So I think at this time, I'll turn it back to you, Rishi, to continue the discussion. Thanks again for the opportunity to provide insight on this important topic.
Great, thank you so much, Melissa. Now I'm going to turn it over to Avani, and have Avani give her thoughts on the article as well.
Yeah, hi, thanks. Thanks so much for having me be a part of this conversation. This is obviously a topic that is near and dear to my heart. And just as a backdrop, pediatric self-management and adherence has been the focus of my research for the last 20 years, and the focus of my colleagues in the Center for Treatment Adherence and Self-Management. And it's one of the reasons that we actually created this model that Amy referenced earlier in her slides. We thought what was lacking in the literature was something to help us understand all the systems and factors that come into play with kids, because the adult literature really didn't account for all the things that our previous speakers have talked about, including the family unit and the healthcare unit and the community in caring for kids and how they manage these things on their own at home. As many of you know, as clinicians, patients are in our office for 20 minutes, but the management of their diseases really happens in the 23 hours and 40 minutes where they're not with us. And that means, we are really charged to help them gain the skills and confidence to manage these medications and treatment regimens on their own when they're at home with our support. And so I have several key thoughts that I've listed on this slide, but I'm going to veer a little bit away from that because I think some of these have been covered in what our previous speakers have said, and really talk through two main things that I think are keys for us to move forward in this area. The first is that we do have quite a bit of research and we have quite a bit of evidence for different measures to use around self-management and adherence, but many of them are disease specific. And so for those of us who work in silo-based diseases, that may be helpful, but they may not be so helpful for patients with more complicated and complex diseases that are multisystemic. And so, one thing I want everyone to consider and think through is, can we borrow from some of these disease-specific measures and take them and use them to suit our needs in clinical practice and better understand, as Melissa just pointed out, what the skills are and what we're trying to shoot for, and what is the role of the parent and what is the role of the child, and how do we partner with both to make sure that the goals of both are met. And the other thing I want to mention is that diversity and culture can also play a key role, and we haven't really talked about that yet in this conversation. And I think it's important to consider that what our goals as healthcare providers are for self-management can look really different for different families based on their own cultural experiences and their expectations of us as a healthcare team, as well as of what they expect of the child versus the parent versus a sibling in certain contexts. So I just want to have that be an overarching way for us to think about things. And then the last thing I'll mention is that we here have at Cincinnati Children's really thought about how we translate this research to clinical practice. It's hard. Self-management's really complex, and I don't think you can fix the system all at once. But one way that we have tried to tackle this is to really hone down in on barriers to adherence. And so I've been working with a group in kidney transplant to, in clinical practice, every time a patient and caregiver come in, they complete a 14-item checklist around the barriers that they are experiencing, and the caregiver completes it and the child completes it independently. And we're often astonished that the barriers that the child may complete and the ones that the caregiver may complete can look really, really different, which highlights some of what Melissa said about those goals maybe being different. So for example, a patient that's 12 or 11 may say that they don't like the taste of a medicine, but the parent just thinks the child's being oppositional and refuses to take it. How we intervene on that and what we do obviously would look really, really different. And so there are lots of things as healthcare providers that we can do around the taste of medicines, and those are certainly things that we can tackle as a team. I echo Amy's comments about the multidisciplinary team being really important. And one aspect of this barriers tool that we're sort of using it for is to really break down different barriers and assign those barriers and interventions with those barriers to particular team members. So barriers that are much more social or psychology related go to our psychosocial providers. Barriers that are more medicine related may go to the actual healthcare provider. And then some logistical barriers may be handled more by a nurse practitioner or a nurse or somebody else that is managing the care. And so by ensuring that we have tools to address these barriers and a point person around each of these barriers, I think we've become a little bit more effective in helping our patients manage their diseases. I'm not saying this is the end-all be-all solution. I'm saying it's just one way to start tackling the issue in a more systematic way, and in a way that we can ensure that both the caregiver and the patient's needs are met. So I'm going to stop there because I know most people like discussion, so I think that's where I'll end.
Great, thank you so much, Ivani. So at this point, we'd like to hear from you, the listeners. We've already gotten some questions, but feel free to continue adding your questions into the chat box. So we got a couple of questions about self-management for specific populations that I'd like to address to the three of you. One is, how do you assess self-management capacity for children with developmental disabilities? And then a corollary to that is, how would one implement a plan of self-management for a pediatric patient with multiple conditions? You know, for example, if one has a life-threatening condition that could affect their other conditions, how do you negotiate that? And you know, I think that gets to a general sort of thought that I had that I'd love for you all to address, is that you know, there's a lot of practitioners in the audience, and very busy practitioners have a lot going on in their practices. If you can think of some concrete examples of how self-management can be promoted and implemented in a busy practice based on the evidence that we have, or any best practices, you know, I think that would be wonderful. So, Amy, I'll first turn it over to you, but then I'd love for all three of you to pipe in.
Sure, thank you, Rishi. So many children with developmental disabilities have cognitive impairments that limit their ability to be fully independent with decision making, and also with their ability to carry through tasks. They might be physically capable of doing things, but not be cognitively capable. And in those situations, unless they're completely dependent on others, they are always have opportunities for choice making and development of autonomy and development of skills. It might be breaking down the task to very, very small pieces. So for someone with developmental disabilities who needs to remember to take their medicine, that sounds like a single task, remember to take your medicine. But there's actually multiple pieces of that task. So you actually have to have a time schedule. So if not being able to tell time is a barrier, then there are adaptive techniques that we can use successfully to remind someone. Someone has to be able to know which pill or medicine to take at the time. And we often use assistive techniques to assist children to know which medicine is which. It's taking the task and breaking it down into its smaller pieces that allow an individual with limitations to be more successful. They might not be able to do the whole task without assistance, or they might not be able to be fully independent without reminders. But that doesn't mean that they can't be engaged and develop self-management skills, and that we should be promoting those at every level. And when I think about developing these skills, I'm often working with occupational therapists who are helping us break down tasks into smaller and smaller pieces, as well as psychologists and neuropsychologists who really can help us identify where people's skills and deficits are, so we can capitalize on what their skills are and then address through adaptations what the challenges are. I think this is key for any task that we are, and this is how we do and tackle any task that's complicated in our lives, is we break it down into smaller pieces. It's being much more concrete about that. And then Rishi, to your last question about how this concretely works in my clinic, is that I'm very lucky to have a multidisciplinary clinic, but I often spend a lot of time in early childhood working with my patients about how it's important for them to know what their medications are and why they take them. And so I'm asking directly to the child questions. What medications do you take? I ask that to the child, but almost all the time the parent does the responding. And then I have an opportunity to do some education and give the child what I call homework. They understand the concept of homework. And then I say that I'm going to ask them next time, and I want their homework to be knowing what those medicines are. And it only takes a few seconds in my clinical practice to be really promoting through this educational opportunity, getting children to accept the responsibility to know and learn, and helping parents understand that part of their role is teaching their child about these things so that eventually they'll be able to manage it on their own, taking it from the spectrum of dependent on the parent to shared management to self-management.
Great. Melissa or Avani, do you have any other thoughts on those questions?
I mean, I think Amy hit the nail on the head. I think you have to break these tasks down into their component parts and then try to figure out where a child who has delays or cognitive disability may be able to do something versus not. And so, I mean, I think those are great suggestions. And I think seems like it can be very time consuming in clinic to ask one or two questions around self-management. But the truth is that it really starts to open up the dialogue and make it more comfortable for families to share the things that might get in the way of managing their disease, which I think can open up a whole new conversation around the treatment regimen and what best to do.
I think too that, remembering to start this young, even when a kid is a toddler, I think it'll make it easier for us in the long run and to build upon those skills with the family.
Great. Thank you to all of you. I want to now pivot to a question that Melissa had posed about how do we have a systematic approach to creating goals, because we had a question from the audience that made the point that sometimes our expectations may not match those of a family's. For example, a family that does not emphasize living outside the home during young adulthood for their young adult. So how do we sort of manage the expectations that we may have as providers and reconciling them with what the goals are for families? Melissa had posed this question. I'd be curious if you all could discuss a little bit. Amy or Avani, do you have any thoughts on that?
I mean, I think this is Avani. I think we just have to ask, right? I think there's families have a lot of ideas on what they may seek or what they want help with. And I think, again, the dialogue and the open conversation in their clinic visits around what their expectations are and what they're hoping for can set the stage for that. And it may be that we have, some type of a document that has the typical skills and self-management skills, and the family can look at it with the provider and say, is that something that you would be shooting for? And what do you guys want to do versus not do? And that can start that conversation. That's just one idea from a logistical standpoint.
I think it's really important for us to have cultural humility and take recognition of where children and families are from what's important to them and what their values are. And when we do shared decision making, whether it's about deciding upon a treatment or promoting self-management, that we're taking into context all of those aspects of what's going on and really addressing what's valuable and important to children and families and what's important towards achieving health outcomes that both the provider and the patient and family have goals around. And it does sometimes take extra effort to have goal alignment, but for the most part, when we're able to talk about what underlies why we want to achieve a certain goal and have relationships with our patients and families that allow them to express what's important and valuable to them, it becomes much easier to engage in shared decision making around goal setting and expectations.
Great, thank you. We have a comment from the audience suggesting that there may be value in referring parents of adolescents to peer support to learn from other parents about moving their children from dependency to independence. And I wanted to get your, this gets to a broader question I have, is there's certainly a role for providers in this, but what is potentially the role of the community and other families out there, or and what other stakeholders might be able to help with this process?
I personally think that peer support is a very powerful resource for families. I mean, because these are other families who that other 23 hours of the day, take care of their kids. And I think they probably have a better understanding of what the families go through. So I would definitely support peer support.
I agree. I think there's some good emerging evidence that peer support programs can be really effective in teaching. I think you have to find the right peers sometimes, but I think they're great programs when they work, both for the child and for the parent.
Okay, great. So we have another question about a patient. This is actually about a specific patient. I have a patient with a type 1 diabetic that is out of compliance. He defers medication supplies for his grandmother to obtain and coordinate. He refuses to independently care for himself. He will be 21 in December. How do I get him to buy into the self-management concept? And there was another point that was made about, that these are issues that are not just applicable to children and youth who have developmental disabilities and medical complexities, that there are challenges with even typically developing young adults in terms of getting them to understand how to enroll in health insurance and whatnot. And obviously adolescence and young adulthood are tricky periods in development, and wondering if you have any thoughts about how to negotiate that those challenges that are often faced in practice.
That's like the question that plagues all of us in clinic, right? I think that's why we're all silent, because it's always hard to know exactly what to do with each individual patient and how you motivate them and what motivates them. And sometimes understanding the barriers to wanting to be independent are going to be really, really important. So for the patient example that we were just given, trying to understand that patient's or young adult's overarching goals for life, whether it's going to school or going to college or going to work settings, and trying to motivate based on that perspective and what motivates that individual is one starting place. But I don't think unfortunately, there's not a golden key to, help every patient in the same way. And that's where the individuality and and us really as providers working with the families to understand what motivates and what gets in the way is critical.
I think
Great,
it's
thanks.
But I welcome Amy and Melissa's thoughts on that too.
This is Amy. I do think it is important to recognize that the developmental trajectory of teenagehood is challenging, whether you have a chronic health condition or medical complexity or disabilities or not. And I do think it's really important to try to get behind why adherence is challenging and not address it at the place where we're just talking about adherence, but what underlies it. What are the barriers? What are the underlying assumptions that the child is bringing to the table about their goals for their life and their opportunities? And it might be that it's discovered that an individual is quite frustrated that they have to do this extra medical care for themselves and is angry and frustrated or doesn't understand the rationale of why it's important. And so until you get at what underlies the non-adherence, it's very hard to successfully and manage and work with someone to address that. And there are maybe things that are quite mutable for that individual. And there may be factors that are not something that the healthcare provider or the health system can change. And putting that into context, I think, can be really valuable in helping both the team of providers as well as the family and the individual to contextualize and understand the greater milieu so that you can successfully work forward. Because we know that youth who are becoming independent actually have poorer health outcomes than children and older adults, because developmentally for all individuals, as we grow, developing our autonomy and developing our sense of self and our own values is a challenging time. And so I think it was very insightful from the individual who made that point about the developmental trajectory of youth and young adulthood, and I appreciate that.
Great. We're getting some questions, and comments about how to handle situations, when a young adult or a teenager or young adult is very severely physically disabled. And we addressed this a little bit, but one person asked, how do I create, how do I promote self-management in that situation? And then we had a comment talking about how suggesting that with some patients families who have developed hopelessness in learning new skills, that designing goals that focus on preventing any loss of function, and that when these goals are pursued, the patient has the opportunity to surprise caregivers, and that can lead to more robust goals being set. And so, this sort of leads me to a question that I've kind of wondered about more broadly, is that, you've addressed, the issues of when the patient may be limited in tasks that self-management tasks that could be performed. And I wonder, is the concept of self-management only applied to transitioning tasks from, say, the family to the patient, or is there a role of looking at some of these principles in terms of what, say, the healthcare system or the clinic, or care coordinators might do, and what the family can sort of take on, themselves as well? Is there any applicability to sort of that mixture of work? So I was wondering if, Amy and others could kind of comment on, just the situation more broadly, because a lot of us do take care of patients who are limited in some of their functioning.
Yes, this is Amy. So I will tackle the individual who has substantial functional disabilities that limit their physical capabilities to do things. So I think that for individuals, even if they're completely dependent on others for all of their care needs, they still have opportunities to engage in self-management, and that's through direction of care. So if you can imagine someone who has a teenager who had a cervical spinal cord injury after diving off of a diving board into a shallow pool, that individual can't physically take a pill and put it in their mouth to swallow it, because they're paralyzed, but they still can direct the care. And so for my patients who have very limited physical abilities, we work towards autonomy in creating direction for care and making decisions about what to do, when, and how it should be done. So some of the training that we work with for individuals who have a lot of physical disabilities is about learning all of the steps that are involved in the delivery of, let's say, taking a medication, and being able to direct another person to do that. We want for all individuals, no matter how severe their disabilities are, for them to be as autonomous and independent as possible and be making decisions that promote their well-being and their desires and their goals. So it does change the relationship because somebody else is still actively doing a task that's usually deemed a self-management task. But for someone who is then able to fully direct that task, they become independent in the key portion that they can become independent in. I'd like to talk a little bit about how that works in the greater healthcare sphere, because it isn't always just happening in the clinical setting. I'm often working with other team members in a more broad team, so in the school district or in the community, such as physical, occupational, and speech therapists and psychologists, to really work at developing autonomy and independence where people are able to do so. And when I think about promoting independence, I'm thinking about ways that we make adaptations for function that isn't there. And one of the things that we know for all individuals is that when we have reminders, we do a better job of remembering things. So for clinics that remind us by text message that we have an upcoming appointment and that we need to fill out our forms, makes it more likely that we will be successful at filling out our forms. And if there are things that can be automated for you clinically that will help your patients with their self-management and adherence, whether it's through a telephone call or application on a phone, it can be very helpful for promoting these self-management skills that carries beyond just the clinical encounter, the face-to-face time. I'd love to hear what the other panelists have to say about this.
I think an area that I personally struggle with a little bit in complex care, and Rishi had, asked about this too, like we have our care coordination assistants and we have a lot of resources in these programs, and at what point are we getting to the point where we're enabling families instead of promoting more independence? We do a lot of the appointment making and making a lot of those decisions for families, and so I think it's kind of a fine line of transitioning that independence over. And I'd be curious to hear what maybe feedback you have on that, how we, just the healthcare system, how we kind of loosen the reins and give them more independence. And we focus more on it, I think, when they are going to adults, youth to adults, but I think it's something that we need to work on earlier on in the course of their lives.
I think that's a great point, Melissa, because, as we transition our pediatric patients to adult care, a lot of those same skill sets for self-management, we're also hoping to transition, right? And so how do you practice those in the safer pediatric environment, like maybe making your own appointment and having some scaffolding or support around that where you try the independence, and then if it doesn't work, then you problem solve around why it didn't work before transition to adult care settings happen and that scaffolding is not there. So I think those things do go hand in hand, and I think it's a great point.
Okay, great. So next question, we had a comment to suggest to everybody to get acquainted with their state's assistive technology resource centers to learn about the huge variety of various assistive technologies that can help with self-management. It's often explained to teens that there are life hacks that can help them care for themselves and eventually help them care for their parents. And that these can be very helpful in promoting independence. And so I was wondering if if all of you could just comment a little bit on the role of technology, both what's available and perhaps what ought to be developed in the future in terms of promoting self-management and and promoting access to those sort of technologies.
This is Amy. I will start. I feel very lucky to be practicing in the field that I'm practicing in now, as technology has really boomed in terms of opportunities for assistance from devices that are available to everyone. So I would say for children with disabilities, one of the biggest things that's really changed is technology that is readily available on the phone or the iPad. And there are many apps that are available for people in general that can be adapted successfully for people with disabilities or chronic conditions in terms of self-management related tasks. And I also would like to thank that listener regarding recommendations to become familiar with what assistive technology options are available. And one other key piece of that is that in young people's IEPs, there's a transition plan for any child who has disabilities that gets special education services. And a transition plan often includes engaging with vocational rehab and other services in the community around the time of transition, and partnering through the IEP or through community resources can be a great avenue for healthcare professionals to help get their young patients prepared successfully for the transition. And a lot of that has to do with opportunities around self-management. And there is a wealth of new and emerging technologies and applications that are available in general and in more specific cases for people who have particular limitations.
Great, thank you. So we're going to have to wrap up soon, but one comment that just came in that I wanted to share is from a parent of a child with medical complexity, who says that we often encounter inconsistencies in the various people who provide care. The doctor is often supportive of self-management, speaking directly to my child whenever possible, but often the first point of contact, a nurse, MA, or receptionist, may not be in line with that, often making assumptions about my child who's small in stature and uses a wheelchair. Often the assumption is that my child is immature or cognitively impaired, so unable to speak for him or herself. And so the parent is making the point that the first point of contact can adversely impact the rest of the visit, resulting in reduced motivation for self-care and management. And so the question posed, for all to think about, we won't really have time to talk, is, are we making sure that we are involving those partners in the discussions, not just the physician, but the other members of the care team? And how do you support a family in that respect? So some wonderful thoughts from a parent for us to conclude on as we move this topic forward. So thank you to all of you in the audience, and thank you to our panelists for a really wonderful discussion. The audience was really engaged. We got a ton of questions. Sorry we weren't able to get to all of them on the time that we have in this hour, but we're going to be going back and answering some of them and posting them on the Packard Foundation website. And throughout 2018, we will be engaging in discussions with other authors and experts in this field on topics in the supplement. The next discussion will be a conversation on protecting rights of children with medical complexity in an era of spending reduction on September 20th. Registration is now back to you on all of that. We are always looking for ways to make these conversations more engaging and welcome your feedback. Please make sure to complete the survey that